Awesome. Well, welcome. Hi, everyone. Welcome to Global Health Core's Shift Happens series. Thank you for joining us today on improving maternal health care for Black, Indigenous, and people of color in our communities. My name is Dr. Ariel Arguelles, and I am the U.S. Community Impact Senior Coordinator here at Global Health Core. I am so delighted and honored to be here with you all with our exceptional speakers who bring with them a wealth of professional and personal experience, and as well as personal activism to this dialogue. And I'm thankful to all of you for joining in this imperative conversation at such an important time in our history. If you haven't already, please add your name, where you're joining us from, also if you're a former GHC fellow, what year you were, where you're located, and if you're not, where you're coming from, because we'd love to hear more about where you're from. So I'll not take too long to introduce the session because I, as mentioned before, want to make sure we have as much time as possible to hear from our speakers. But again, I am so grateful, I'm humbled to have so many fantastic alumni with us today, especially our panelists. All of them have a nursing background, which, as we know, is one of the most trusted professions. Most are also doulas and have experience in birth and birthing. So I'm really pleased to be here with you all today and to be with them who provide such great experience into this really important and really pressing topic. And so first, I'd love to introduce Dr. Abiola Abubakar, who is an advanced practice public health nurse, healthcare innovation consultant, and the co-founder of the BA Collective. She's a doula with a passion for promoting accessible healthcare and health education in her local and global community. Our second panelist today is Angelica Riciedo. She's a medical writer, editor, content strategist. She's on the editorial team here at Doximity, and which is the largest online medical professional network in the US. And then last, but certainly not least, our third panelist is Gabby Romero. She has a master's prepared registered nurse, doula, and dynamic health educator with a passion to promote health equity for the most vulnerable populations, both locally and globally. She's currently a nurse midwifery student at the University of Alabama, Birmingham. So thank you all again for joining. Thank you today to our panelists. I'm really excited for a great discussion. I'm only sad that we have an hour, so I hope that everyone on the line, you will also share your insights, your comments, questions in the chat if you have the chance to. And then at the end, we'll open up the floor for some questions and also to continue the conversation in a different way. So to begin, I want to first frame our thinking that when we talk about improving maternal health care in the United States and what that means specifically for our communities. A conversation on maternal health care can't first happen without discussing reproductive justice, which, as defined by Nonprofit Quarterly, takes a more holistic approach to bearing and raising children, moving beyond the rhetoric of choice, which hasn't always been meaningful to women of color. This asks, what are the social, political, cultural, and economic conditions under which women, non-binary, and gender non-conforming people and trans men can choose to have children? How does our society make pregnancy an easy choice for some people and a difficult question or forced burden for others? In that, I ask today that we create a space to use gender-inclusive language and recognize that when we speak about maternal health care, that includes each aspect of maternal health care and its outcomes. So with that, for our first question, I actually wanted to address it to Angelica, as some mentioned on the call before. This is a very important time in the United States when it comes to reproductive justice and reproductive rights. As we know, just over a year ago, the Supreme Court overturned the federal constitutional right to abortion. And in light of this, Angelica, first to you and then to the rest of our panelists, could you please share more of your experiences in that shift and that change in the past year, and what can healthcare allies do in that process?
Thank you, Ariel. Morning from California. Well, being in California, for one, is a really interesting place to be in the past year, and watching the state become more of a sanctuary state. I know my fellow panelists are coming from the Midwest and the South, and it's not the same, obviously, state to state. And working at Doximity, the largest medical network, I'm pretty in tune with what a lot of obstetric and gynecological providers are kind of feeling and saying right now. And the tone is definitely tense, very nervous about their own licenses. For example, I believe 4 in 10 OB-GYNs right now aren't sure like what they're allowed to do. They're fearing like being reprimanded, for even providing abortion information. So it's not even just not being able to prescribe or provide certain services. Some are even afraid to talk about it in the exam room, which is pretty scary that it's being omitted completely, that knowledge, that information. So that's what I've been seeing, is that a lot, it's varying state to state. Women are traveling, right? Crossing state borders, international borders to seek care a lot. And so that's putting a lot of strain on sanctuary states like California, who have to kind of step up and change their legislation to welcome more and more birthing people into the state to seek care. So that's just a couple of things I'm noticing within the past year, and clinics shutting down, right? And so yeah, definitely want to hear from Gabby and Dr. Abiola on what they're seeing like in their locales as well.
Abby, if you would like to go next.
So I'm currently based in Birmingham, Alabama, and overall in the South, if you look at a map, this is the area just has one of the most restrictive laws related to reproductive justice and abortion for childbearing people. About 93% of the counties in Alabama don't have access to abortion providers. And as a midwifery student, it's part of our core competencies. So we're really struggling with that in terms of how do we get this knowledge. It may look like something that we focus on later after we graduate, but it's a pretty dire situation here in Alabama. Even the statistics that you can find don't have access to where you can find an abortion provider here in the state, because it's very, very restrictive. And just like people are going to California, people are from Alabama are going out of state and very far to get access to abortion care.
Thank you for sharing. Dr. Abiola, do you have anything to add?
Yeah, first off, good morning, everyone. I'm joining today from Oaxaca, but a lot of my work is focused, as Angelica had mentioned earlier, in the Midwest. So I do a lot of my work specifically in Minnesota, and Minnesota is very lucky to be a sanctuary state when it comes to abortion access. But I will say that I think this is where policy and action get really interesting, because while we are a sanctuary state and we have great policy around protecting abortion care, Minnesota is one of the states with one of the worst racial and health gaps in the country. So we see a lot of disparities and inequities depending on your race in the state of Minnesota. So it's like, while we have this great policy in place, what does that mean in action? And that's a lot of what we're seeing. So while abortion is protected in the state of Minnesota, what does that mean when you're trying to receive care in a state and a healthcare system that has some of the worst racial and health inequities in the country?
Absolutely. And that's part of the reason, if not one of the major reasons, why we wanted to have this conversation, speaking specifically to that racial disparities, because as we know, it's reproductive justice encompasses both having the ability to choose to terminate a pregnancy, as well as the entire process, if you do decide to continue with it, how the process works, how you're able to find prenatal care, how to even access the right doctors, or to ask the right questions, ask the right nurses, and kind of have all of that access. Dr. Abiola, you mentioned that the policy aspect of that and how that can affect racial minorities. I hesitate to use the word minorities, but it's like those who are of the non-white population, the Black community, Indigenous community, and other people of color, how that influences in that policy level from a top-down approach. If you could speak a little bit more on how policies can both help and harm access to maternal care.
Yes, definitely. Continuing what I was talking about before, right? Like, we can be in very progressive states, and that's why I'm so excited about our panelists and our geographic locations today, because we are coming from very different parts of the US, and we have different aspects of policy that are impacting the work that we can do and the work that we see. But then there's this other layer, even more nuanced layer of racial inequities that we see here in the US. So specifically, one thing that we've seen a lot, or that I've seen a lot in my work thus far, is that we will have policy, whether it be at the national level, and honestly, when it comes to a lot of the birth justice work, a lot of the great policy we're seeing is actually coming from individual states. We're still trying to get the omnibus through at the national level, but a lot of the great policy work we're seeing is coming from individual states. And at the same time, this policy is being written in a way that it puts equity at the forefront. But then once again, in action, what does that equity look like in action when we don't have systems that enable equity, when we don't have systems that support and protect equity? And even more specifically, I think about in Minnesota, once again, we had a great opportunity to have a really great doula reimbursement bill come through. And that's been in progress for a long time. We've had amazing providers and people at the grassroots level really pushing that work. And we were able to get doula reimbursement for Medicaid patients in the state of Minnesota. And recently, in this most recent legislative season, we've been able to increase the reimbursement rate. But that was a bill that was written with so much equity in mind, and specifically racial equity in mind. But then in action, it actually ended up creating inequity, because you had doulas being reimbursed at very low rates. So then you had doulas who weren't taking on Medicaid clients because the reimbursement rates didn't make sense. You had all of this, it was really focused on equity, and then in action it ended up promoting inequity, because you were now being inequitable to the doulas who are supposed to be supporting and providing care for a lot of these racially diverse communities. So once again, thinking about, especially as a grassroots level, and especially as people in this GHC community and in the larger community, what does it look like for us to continue to think about that translation of policy into action, and how it can quickly go from equity to inequity, because it happens so often.
Absolutely. And you bring up a great point that I think we can acknowledge in this group, as well as the society, that any of these interventions and anything that we do is nuanced, right? There's layers to it. It's this, just to repeat what you said, it's like you have this policy that is meant to be equitable, but because of a variety of different outcomes, it ends up being inequitable, because you are on paper being paid for the services that you're providing, but you will also be paying at a much lower level than what you are acclimated to or are deserving of. And especially when you are working towards, in communities of Black and Indigenous and people of color, it's like there's already an inequity that just kind of built into there. And so, Gabby, for this next question, I'd love to redirect it to you. First, I recognize that a lot of people that are here are of interest, are interested in this field and may know, but this was a public event. And so I'd love it first if you could define, for those in the audience who may not know, the difference between a doula and a midwife, if there is one, and your own experiences, because I know that you have experience in the Southern US and that kind of access to doula midwifery here. If you could please share and explain a little bit more of that for our audience.
That's a great question, and I get that question all the time. So the way I like to think about it is both doulas and midwives have a role in birth work and birth justice. The focus is different. While a doula may be someone from various backgrounds, their focus is on advocating and really taking care of the person, spiritually, mentally, and being a support person for a birthing person. While a midwife has specialized training, there's several routes to become a midwife. I'm more specifically knowledgeable about nurse midwives, but midwives of all backgrounds have a specialization in midwifery, and they take care of a birthing person in terms of the labor and delivery process, so the physiological birth aspect. However, both midwives and doulas are there to contribute to birth equity in terms of lower rates of C-sections, lower rates of birth trauma, just an overall better experience in the birth world. And there are plenty of studies that have shown that having both doulas and midwives are particularly important for people of color because they can be there as an advocate for them, especially when you have concordance between race and ethnicity and culture there as well. So I hope that answers your question.
It absolutely does. Thank you. And I'd love to hear a little bit more in your own personal experience, if you don't mind sharing, of working in the Southern US, if you've seen any of that, any of the differences, or essentially just a highlight, you think, of that, having that access, how that can possibly both change or alter someone's birthing experience.
So I will say, as working as a doula and as a midwifery student, the idea that you have someone there to advocate for you, especially when birth has become very medicalized in the US. And so you see this idea that the providers are the people who know everything. And there's this level of like almost of disparity in power that you see. And I think having looking into having a support person, whether it be a doula or having a provider that is more, has a focus on birth equity or power dynamics and trauma-informed care. There's so much research to show that 84% of births of maternal mortality can be reduced by having doulas and midwives in your care. And this is really, really important for this population that we're talking about, specifically Black women who have some of the highest rates of maternal and infant mortality.
Absolutely. Yes, I think the CDC came out and I think it was in 2022 that it was like Black women and Asian American women are ranked amongst the highest of having maternal mortality rates in the US. And it's like when we see that and we recognize that, it's like, what can we do as allies, as healthcare providers, and health people who are working in healthcare to be able to provide that? And there's something that you mentioned that I wanted to direct to Angelica, this idea of having this community, right, where you have the access to not just choice, both choice in to continue with a pregnancy or not, but also choice in how you have access to care, what kind of care you receive, the kind of support that you have. And so, Angelica, I know that you have some experience both in California and New York. I would love to hear a little bit more of your background and expertise in community interventions, such as hotlines, community baby showers, the kind of interventions that may not be as prevalent across the country, and maybe some of your insight of the things that you've seen as a reporter.
Yeah, thank you. I had the pleasure of speaking with two PAs, physician associates, they work in Long Island with the Shinnecock Nation of indigenous people. And they informed me, I wasn't even aware of this statistic, that Native and indigenous women are at the highest rate of pregnancy-related suicide. Very sad. And they have been working on a great project with the Postpartum Center of New York to develop a hotline that's like, very culturally specific, uses their own local language and like cultural customs to really engage with the women there and talk about, suicide and like mental health, which is so important and definitely like not talked about, like mood disorders and things that women experience. It's very like hush hush. I feel like, you're supposed to be so happy when you have a baby and like bringing in new life, that no one talks about, like that there are hormonal changes, and it's normal and it can be medicated, it can be helped. So like if you're feeling sad or you might want to harm yourself or harm your baby, like there are people that can help, and that's considered an emergency just as much as, a hemorrhage or like psychiatric emergencies among women in the postpartum period are definitely overlooked. And these hotlines, feeling like you can trust someone you're talking to and you won't be judged, like the stigma, they were telling me is a big barrier. Like even if they are feeling sad or like they can't provide for their babies, like they think it's not normal. They think like, oh, I gotta kind of, be a good mom. I have to be strong. And that's really like a narrative that we shouldn't be promoting, that like you have to do this alone, you know, like, and we're seeing that more with the rise of community baby showers, which I think is a great idea. I've heard of them popping up in New York City and the Bronx in particular, where, you know, 1 in 3 women are living in poverty there. And having these showers that are put on usually by like the health department, and like you have other community-based organizations helping, donating like supplies, food, diapers, clothing. A lot of these women can't afford their own baby showers, so to really be in community with other women is really helpful. And I think so important to check in on, you know, birthing people in your own like families and personal circles, because it may seem like a happy time, but if you're missing out on your resources and things, it's, you might not be very forward about sharing, you know, what might be going wrong. And a lot of things, right, we know clinically can go wrong in a pregnancy. And I feel like even miscarrying, or my own sister, she lost a baby to SIDS a couple years ago, and these things just aren't talked about. Like it's it can be a dark time, and it's hard to experience that alone. So I definitely encourage like checking in on women and your neighbors, you know, who you may know. Yeah.
Thank you. And thank you for sharing that. I appreciate your vulnerability and sharing that with us and your history. I agree that it's one of those things that we don't talk about this. We can, that's a whole separate shift happens about the medicalization of how that works for women, the medicalization of practice and care, and how that affects women who are non-white, and all of these different sectors of that. But something that you very specifically mentioned that I wanted to highlight and present as a question to all of the panelists. It's this idea and this concept of not knowing what is okay to say, right? Or not knowing something that's not normative. This is not something that we talk about. We don't talk about, I mean, in the United States, talking about sex education or periods and even reproductive cycles, even that in certain parts of the US. I should disclose, I came born and raised in Houston, Texas. So I'm from the South, and even regional differences in how people are able to have access to education and healthcare can drastically different from where you are, where you're located, where you're from. To the panelists, I'd love to hear, Angelica, thank you for sharing some of the insights that you've seen in New York. For those of us who, my background is in healthcare policy and community development, but I'm not a doula, I'm not a midwife, I'm not a clinical practicing physician, and yet this is something that's very important to me as someone who wants to be in alliance with and support those who are choosing to give birth, those who are in their birthing journey. What can allies, or those of us who are not clinically affiliated or have the clinical knowledge, what are some solutions or suggestions that you would have for us to think about how we can kind of change the narrative that's currently going through, and the statistics if possible?
I'm going to jump in here and share. So my sister and I have a doula practice called a BA Collective. And a big part of the work we do is the ways in which we check in with people. I think a lot of what Angelica was talking about is how do you build community? How do you support people in building community? And it's just not the work that we do, me and my sister do as doulas for a BA Collective. It's the work that a lot of doulas and a lot of people in the birth justice movement do. And it's really about checking in on people. And I think that's a message that can be applied to so many aspects of our lives in general, but intentionally checking in on people. In the US especially, there's a 6-week mark for postpartum checkups, right, for birthing people. So that means you're not seeing a provider to learn more about what's happening to your body, to figure out what's happening with you as your hormones change, right? Because we've talked about hormonal changes in birth. You're not seeing anyone until 6 weeks. Your baby, on the other hand, is seeing someone like 5 days to 1 week right after being born. So what messages is already sending about the importance of your well-being as a birthing person, the importance of your support of your community. And for us as doulas, it's really important that we make it a point to, yes, we have our 6 weeks checkup with our doula clients as well, where we do a lot of the mental health work, but then we also have checkups honestly every single week after they give birth up until that first 6-week checkup, because it can be a very lonely, confusing time. There are 1,000 books on birth, and I always say there's 1,001 books on birth, because there is no one path to do this, and there's no one opinion or right opinion or fact on how to do it. So it's really just supporting people in one, affirming them, affirming their feelings, but then also affirming their experiences of birthing people and saying, right, like, you're making your own rules. This is your own story, and really supporting people and owning that. And it all starts with a check-in. So I think that's something that anybody can do with a birthing person in their life. I will also add, though, for people in this space, so now, like, switching positions in my work as a healthcare innovation consultant, a lot of the work I do in the space of birth equity really focuses on, for allies, for clinicians, for anybody in this focus of birth work, or even in the clinical space. I always say, before you start anything, before you step in with any solution, practice anything, step back and really get bearings for yourself. I think a lot of the unfortunate realities that we're seeing, especially for Black birthing people in the US, comes from ego, fear, insecurity, and a lack of self-understanding of ourselves as people who work in these systems and promote these systems of health, right? So before doing anything, what does it look like for you to step back, check your privilege, understand your identities? Because until you understand yourself, everything around you can feel like a threat, right, to your reality, to your experiences, to everything. So there's a lot of work that we have to do as allies, as clinicians, as people who are in community support birthing people, to really check in on ourselves and therefore check our biases as well. So that's a big piece for me as well. It's like, we put so much onus on the birthing person. We're like, find community, do all of that. And there's less onus put on us as people who are supposed to be in this space of supporting and actually supporting great healthcare outcomes, to really be like, right, the system is made of people. We are the people that create the system. So we got to focus on what we're not doing right as well.
Yeah, I think there's so many great points that both of you brought up. One, I love that we're talking about perinatal mental health. That is such a huge issue that is so secretive and so stigmatized. And that's something where I kind of want to do my future work. And I think there's a lot of lessons learned from other issues that we often don't think about. So my background before going into nursing was suicide prevention. And in suicide prevention, there's this idea of building a safety net, and it starts early, whether that be coping skills during pregnancy, coping skills as a child, training teachers, training clinicians, training lay people to identify people who are at risk for depression or suicide. And there's also this great emphasis on, like Dr. Abiole was saying, this idea of listening before you act and really engaging the people who are impacted. So whether that be someone who has been impacted by, birth inequity in terms of racism, whether that be in terms of experiencing postpartum depression, and not assuming that because you have a degree or a clinical degree, that you are the expert, and really building this safety net for birthing people. And we know that one of the things that sticks with me from GHC was a presentation by Dr. Agnes Binagwaho, I believe is her name. She was the former Prime Minister of Health in Rwanda. And it sticks in my head to this day, the idea that you can't build a health system without building it for the most vulnerable, because if it doesn't work for the most vulnerable, it's not going to work. And I think that's how we have to think about any issue, whether it be mental health or maternal health inequities, and really valuing the opinions and the most vulnerable in their work.
Thank you both. Yeah, these are a lot of great points you bring up. And I think back to the working with a lot of clinicians on doximity, that there are a lot of people who are now in this kind of hostile and like tense times of not even wanting to enter like the obstetric workforce. So I'm thinking that there will be like a labor shortage of nurses, doctors, all sorts of clinicians, and that's making me very concerned for, future people who are giving birth and like having families, that there just won't be enough providers, period, and then enough providers who look like them. Like we know that Black babies do better if they're cared for Black clinicians. So if they're, where are they? Like we have to be investing in those medical students, nursing students, all of the care team that's coming together, right? Like we need the doula there, we need the midwife there, we need everyone like present. And even just knowing that one bad interaction at the hospital or in the clinic can really affect people and make them feel like they're not heard or seen. Like we know a lot of Black women's pain is dismissed, their birth plans are dismissed, all their wishes and like the plans they make are not being taken into account, and that just can't be like acceptable. So it really has to be everything in the community, in the hospital, everyone that touches like a pregnant person and their family like has to be aware of like, these interactions stay with people, and it doesn't matter if you're more educated, like the more degrees you have, it doesn't protect you. Like racism doesn't follow economic lines. People with even higher educated Black women are still dying at a higher rate than like similar peers, white women who are similarly highly educated. And housing, I remember when I did my GHC fellowship in Boston, at the Health Commission there, I was sat on a committee where they really equated birth justice with housing justice. And it made a lot of sense to me that, if you don't have a stable home, if you're not like living in a safe neighborhood and you have like access to healthy foods, like all of these social determinants of health that we learn about in school comes into play with, having a family and doing it safely. And if all of those things are missing, like, it's just not going to work out for the family. Like the baby isn't going to be healthy, the mom isn't going to be healthy. So even if you don't work directly in like maternal health, if you work in housing, if you work in nutrition, if you're a social worker, like there are still ways to touch like families and like help families and birthing people.
Excellent. Thank you all for sharing. And I think you all bring such great points. I was writing something down. I was like, Dr. Abiola, you're saying we're the people creating the system, or racism doesn't follow economic lines. It's like this idea that it's a really good reminder for those of us who are not clinical or who are not working directly in the field, that it's something that we know at Global Health Corps. It's in the name. It's global health. Global health is holistic. It's looking at each and every aspect of health and health interventions, how it works. As I previously mentioned, my experiences in health policy on the federal level. And so it's like health policy on the federal level, that seems like such a big picture thing in the US. And yet, as Dr. Abiola had mentioned, those trickle down effects and how that actually works in practice, or what Angelica had mentioned, how you are able to have the policy or the not off the books, like how someone is able to build a community and be able to help, is really important. It's really important reminder for the things that we're trying to accomplish, which is having happier and healthier outcomes for birthing people, especially people who are Black, Indigenous, and other people of color. And in that, in thinking of those interventions and thinking of the things that we all can be a part of and that we all can do, Dr. Abiola actually wanted to speak a little bit more of the community aspect in terms of those who are maybe foreign born, or those who are not white, like Black, Indigenous, people of color communities. So like you had mentioned previously, that you have this experience of like this immigrant paradox, and like having this perspective of how you have access, maybe like even if you have someone who has all of the access in all the world, but maybe you have a different experience, you have a different way of communicating, not necessarily just in terms of like a language barrier, but just the words, terminology, just the entire scope of experience can be very different. In thinking of these ways that we can approach the birth experience for birthing people from this holistic way, I'd love to hear if you could provide a little bit more context and more of your experience in that sphere.
Yes, so I will start off by sharing the immigrant paradox. This is paradox that I'm sure many of you are familiar with, but it's this reality that when people come to the United States and they immigrate to the United States, foreign-born people, oftentimes we look at it from foreign-born Black birthing people, you see a decrease in their health outcomes, in positive health outcomes for them. The longer that they stay in the US, the worse that their health gets. And this can be said about many immigrants. And the reason why I like to invoke this in, or I think it's important to invoke it in conversations, especially around maternal health, is because we are a nation of immigrants, right? So what does that really mean if we know that the systems, once again, we are the systems, and the communities that we're in are causing this like degradation of our health and our well-being. There's also another term that is often spoken about when we speak about the Black maternal health crisis, which is weathering. So if you are a Black person, specifically a Black birthing person, even more so as we speak about in this context, just being in the US, right? Being in a state of constant, like you're constantly stressed, you constantly have higher levels of cortisone than the general population. You're constantly under pressure in different ways, and how that impacts your health and your well-being, and even more so, how does that impact your birth experience and then the birth outcomes that you have? We know the statistics, right? We've talked about how Black women in the United States, or Black birthing people in the United States, are 3 times more likely to die during birth. And it's not because they're Black, it's not anything about their biology, because we know that it's not about race, it's racism. It's because of the types of care that they're getting. It's because of the types of care that they're actually not getting, and how this larger system plays into it. I think it's really important to know what Angelica had said before about building community and how community can really support with that, because it's this reality of saying, okay, well, we know this is happening. How do we address it? And a first piece of addressing it is like, how do you feel more comfortable with a provider who looks like you? Once again, to Angelica's point, we had Dr. Rachel Hardiman and other colleagues who published a journal article that literally told us Black children that are born in the care of Black providers have a higher chance of living past their first year of birth. Like, that's a very scary thought. It's a very real thought. In the state of Minnesota specifically, research has been done that shows there is no safe, and there's like many measurements around safety, but there's no safe place to give birth or be born as a Black person. So there's this larger piece of, once again, and this is my whole thing. So if you don't know me, now you do. I'm always talking about systems. And even more so when I talk about systems, I'm talking about people. I'm talking about, like Angelica had said, whether you work in social work, whether you work in the music industry, wherever you are, we are the systems that we are constantly berating. Right? So what does it take for us to have that understanding of, first off, who we are, and then how our actions impact others around us? It is terrifying, and I have conversations about this with friends, other Black birthing people all the time. It is terrifying to be in this space where it's like, yes, I have these degrees, yes, I have this knowledge, yes, I have these abilities, and that will not protect me, because we know there are no protective factors for Black birthing people in the United States. We had Dr. Shalon Irving, who passed away, Tori Bowen, who recently, or Tori Bowie, my apologies, who recently passed away. We know about Serena Williams, we know about Beyonce, we know about all of these very high profile Black birthing people in the United States who have not had optimal outcomes simply because of the effects of racism. And then we also, it gets even more nuanced when we start to think about our friends and colleagues at the intersections of race, sexuality, gender orientation, and so on and so forth. So now what does it look like for a Black birthing person who identifies as trans, right? What does that community look like? Who is checking in on them? In what ways are they being checked in on? So I always say, like, it starts with this real, for us, it's really important to have this deep understanding of who we are, and then who are the people around us, and how are we in relation with them, and how are we in relationship with them? And like, when I think about solutions for this work, and I think about building community in this work, it's always that.
Absolutely. Gabby and Angelica, I could see that you had strong affirmation of that. Is there anything that you'd like to share or add on to what Dr. Abiola had said?
I just wanted to, I really appreciate that you mentioned weathering, Dr. Abiola, because that is something that not many people know about. And I think it really describes the experience of going through chronic stress and historical racism, structural racism, as a source of of that chronic stress. I also, I really enjoyed that somebody brought up housing, Angelica. I think the idea that, I mean, there's plenty of evidence to show that physical environment, whether that be exposure to toxic chemicals, also impacts maternal health, and how that disproportionately affects childbirthing people of color. And one of the things that I think about in Alabama specifically is just the lack of data around this. So there's just, when I was looking at this talk, I spent a lot of time trying to find data specifically for the Southern US. And there's data for state-specific information related to maternal health, but there's just this dearth of research in terms of the Southern US. And to me, like, what does that say? That we're not valuing these people, that we don't care enough to look this up, to find out information, to translate that into everyday language for people will know. So I think this intersection of research and clinical and community is just really, really important.
Absolutely.
I'm furiously taking notes on all of our, I feel like we're covering a lot. This is great. And a couple more points that I want to bring up is that you know, the health of the mother, of the birthing person, like, will affect their child's life forever as well. So if you're born premature, right, like, and then you're faced with higher rates of obesity, diabetes, hypertension, like, the mom is carrying like generations of institutionalized historical racism, and it's carrying into the family, it's being passed down. So maternal health it's not just this small phase in a person's life, it's lifetime health. So prenatal care is primary care. And you know, that when you have people coming in from prenatal care in their second, third trimester, we've already missed out on a critical window. So this means investing in primary care as well, and getting people in the door even before they're even thinking of getting pregnant. Like, honestly, like, that all has to get started way in advance. So it is crucial, like, months, years before, like, they tell us, right, even start taking folic acid now. Like, if you're like even thinking of, so it's like, if you're already behind and you don't know all these little things that because you don't have insurance, or you're not, you know, how can you even catch up when you're that behind? And even so it's really, I think of it a lot like even working in tech, like my company's a health tech company in San Francisco, and just what's the privileges that, you know, certain people can have. And if you're a tech worker, and like, we even have funds for like egg freezing and like all these sorts of things to be able to plan our lives, build our families, and all this. It's like, there's a lot of policies missing. And I think a lot of people were excited and wanting to get involved in 2020, right after the killing of George Floyd, like, in investing in Black organizations and Black communities, but that those funds have run out. You know, it's 2023 now, and like, have people like forgotten, or have, like, it has to be sustained. And that means like talking to your legislators, your lawmakers, and supporting different bills. Like, I recently heard of the Momnibus Act in California that was passed in 2021, and they're trying to provide basic income for up to a year for birthing people. And that's great, but it's, why is everything done by 6 weeks, 6 months, a year? You know what, like, it's not going to be enough. And like, thinking of into like childhood too, like we're talking about the chronic conditions that develop after the pregnancy and the checking in. So it really is a wider scope, maternal health, and I think we're thinking too narrowly sometimes with interventions and legislation.
Absolutely. This is a lot of wonderful information. Gabby, did you have anything to add on to that?
Yeah, this made me think of one of the things that I love sharing with people is talking about adverse childhood experiences and how that impacts health. And particularly for rural communities, and that's mostly where I've worked, this is something that's particularly for the South, how people in rural areas generally have higher rates of adverse childhood experiences and how that influences their health for their lifetime. And in turn influences their family's health. And I think this idea of prevention is just so important. And it's like Angelica was saying, it's so, we view it, maternal health, so narrowly. And how it's just amazing to me that there's so many places where there's so much emphasis on prevention and we're stuck at 9 months.
Absolutely. That's the one thing that I wanted to mention, because again, there's so much here. I'm so glad this is being recorded so I can go back to it and just really absorb everything that everyone has shared, because there's so many different levels and layers. Angelica, you were talking about limiting the scope. It's in public health, as many people on our call will recognize and know today, it's like public health is prevention work, right? Public health is not just the treatment of disease, but it's it's preventing the disease can occur. Or Dr. Abiola, you were mentioning just this idea of like the potential to be a birthing person. It's like, that's not something that I would not have ever considered. And I'm someone who is educated, working in the field, working and surrounded amongst people who are knowledgeable of that. And yet even then that thought process for myself, it's like, oh, having that realization not only was affirming for me, but hopeful that in having these kinds of conversations, yes, we're a very targeted core group of people here and we advertised it broadly, but even having this conversation, having this space to be able to talk about these things, to name these things around so-called experts. I say so-called for myself because I am not a birthing person experience expert in that perspective, but it's like to have those opportunities to put names to things or to have knowledge of these things is so important. And I think this is an important first step to be able to better understand that. There was another thing that was mentioned in the chat about epigenetics and how that can influence. That's something that I was like, that's another shift happens about talking about racism and how it's deeply embedded into our research. I know, Gabby, that you have experience in both the clinical and in the research and how that can influence. You had mentioned just trying to find data and information can be very difficult, and that's part of the battle, right? I hesitate to use battle terminology, but it's, if you don't understand a population group, if you don't understand the people that you are trying to address or help, then you are not able to provide good solutions to that, or any solutions. Or even speaking specifically to what Dr. Abiola had said, this is something that's really why we had that inclusive statement at the very beginning, and why it's really important that when we talk about the birthing experience for birthing people, we're also very specific in who we are referring to. Because yes, the title of this webinar is BIPOC. And yet, when we speak about this broadly, that's from non-white perspective. If we're speaking about maternal mortality specifically for Black birthing people, it's important, even just from a terminology perspective, that we are acknowledging that this is an issue specifically for Black birthing people, or for Indigenous birthing people, or for X, Y, and Z. Not necessarily as a means of dividing further, but more to make sure that, as Gabby was saying, if you don't have the specific research for a specific people group, then the solutions or the interventions that might work in here could possibly transfer over, but we're not working from a good baseline level to be able to better understand these things. So just another layer and thought, and just trying to encapsulate all these wonderful things that everyone has been speaking about in the panelists and all your experiences. I know we're getting close to time. And so in this time, I know that we have a lot of people who said that they had some questions, that they were really interested in this topic. And so I would love to open it up if in the chat, if you feel comfortable going off of mute, maybe directed to any of our panelists or anyone specific. I'd love to open up the floor for any questions that anyone in our audience might have.
I have a question. So the problem is so big, right? It's kind of overwhelming. What can we do? You know, what can be done? is there advice or ideas around that? Abiola was saying that wherever you are, we are the system, right? So what can we do as part of that system? Dr. Abiola, sorry about that, Dr. Abiola.
I'd love to learn more about your specific community, where you're coming from, and the kind of work you do, and perhaps we can really think of tailored ways to help out your community there and the people that you interact with.
Sure. I'm not in the medical community. I also live in Minnesota, in the Twin Cities. I run my own business. Again, I guess at the beginning of this, I had said that this topic is timely. Just feels like you're hearing more and more about it. And, I'm not a person who is about to give birth anytime soon. But I just want to know, how can I help? How can I support the medical community more with this? I was also feverishly taking down notes too, and something that was also said was checking in on people, and that your first checkup is after 6 weeks, but what are you doing between birth and 6 weeks? So any advice or thoughts there?
Yeah, I think as a business owner too, in your community, I don't know what kind of business you own, but investing in other women-owned, Black-owned businesses, that kind of indirectly helps out Black women, Black families, if they're being economically supported and being checked in on, and kind of like the community baby showers I brought up too, those are kind of fun ways to really get in touch and celebrate bringing in new life, but also making sure people are having their resources and checking in, even planning fun block parties, or I feel like it can be a lot of doom and gloom this field, and it is nice to just check it and celebrate too. There is so much to enjoy and in being a new parent and bringing in new life. So that can be a role as a business owner in your community to check in and kind of bring joy and spread that kind of love and support in your own way.
I will add on to that in sharing. I think that was really great, Angelica, and I'll add on to that in sharing about once again, we are the systems. So oftentimes people are constantly, and I know all the panelists know this, asking us what can we do? What can we do? What can we do? And I think it becomes easier to figure out as a community what we can do when once again, we understand the context of everything. So I always ask people, when was the last time you've been asked to identify the ways in which you uphold and promote the inequity that we see in our systems, right? And in your specific line of work, when was the last time you've been asked to reflect on that, right? And just starting there, in what ways am I upholding this? The last time I asked myself this was when I was going through my doula training as a nurse, and specifically a nurse practitioner. And I'm going through this training, which is really highlighting all of the ways in which me as a nurse and in the work I do, I am promoting and upholding inequity, right? And it's just it seems like a very big question, and it is a very big question, but it's not a question that we are encouraged to ask ourselves. So that's what I get at whenever I encourage others to think about this. I'm always take a step back and think about you, right? How are you upholding this? And it's a huge question, but in the little things, right? Does your organization only provide money to certain other organizations? Who does your organization partner with? Who do they not partner with? Are you really quiet in certain meetings and louder in other meetings? Literally starting at the basics there and allowing that to propel you, allowing that to act as a catalyst for what you can then do in your scope of work.
Thank you both.
I just, from a clinical perspective, we talk a lot about increasing diversity in providers and also acknowledging that not everybody has access to healthcare. And I think that is something that a lot of people don't know. I think when you hear America, you assume this idea that everyone has access to healthcare. And I think that's something that is so false. And we know how this impacts those who are at the margins, particularly. And when you look at the South, you look at the map for Medicaid expansion and there's nothing there. And at the same time, I think about those who are marginalized, who are in clinical settings, and making sure there's a seat at the table for yourself and for others. That can mean being the squeaky wheel, and also acknowledging how, for those of us who are the squeaky wheel, how exhausting that can be. And so giving people that support. So not always having to be the person who's like, hey, what about this? What about these people? Being that person who is saying, what about these people? It doesn't always have to be the person, the one person of color or the one person who's marginalized. And that can give so much support to the person who's always a squeaky wheel. And so I think there's just so many levels to this, and I'm just really thankful to be in part of this conversation.
Yes, thank you all so much. Unfortunately, as I mentioned at the very beginning, I knew that an hour would not be enough time for all of the discussion and all the great things that we are trying, but we made our best effort. I wanted to thank all of the panelists for joining us today and for sharing their experiences, for their vulnerability and for their honesty, for their expertise. And I also wanted to thank all of you for joining us today, not just in participating in this listening and this learning, but as something that Gabby was just mentioning, it's like to be able to better understand ourselves and to reflect. Dr. Abiola had mentioned it, to reflect on ourselves, but also to take that moment to be kind and gracious to ourselves, that this is hard work. This is a hard field. This is not something that's going to be easily solved, but just because it is not easily solved doesn't mean it's not worth trying. And in that trying, to have grace and patience, both with ourselves, with the squeaky wheel, and understanding how we can be better part of the system that we are in, and how we can possibly change it. So thank you all again so much for coming. I really appreciate you all, and I hope you all have a wonderful rest of your day.
Thank you, everyone. Bye.